welcome. We're back again with Staci Stevens. I'm Annette Whittemore. We're here today to talk a little bit more about energy management and chronic illness. Staci, as you remember, is the founder of WorkWell Foundation and co-president of the International Association of CFS-ME. She holds a bachelor's degree in sports medicine and a master's degree in exercise physiology from the University of the Pacific in Stockton, California. Morning. Or I should say good afternoon. That's right. It just turned to noon. We're so happy all of you could join us again today, and we hope that we're going to be able to answer more of your questions and provide a few more practical tips on how to manage your illness so that you do avoid some of the flares and bad side effects, making your illness even more difficult to deal with. Staci, would you like to start telling us a little bit about our conversation last week, just to bring people up to speed or to inform those who this may be their very first time with us?
Hi, I'm Staci. If you didn't tune in for the first webinar, we talked about energy management and chronic illness and what the problems are, what you needed to know, how to better manage your illness. If you missed it, you can catch that on workwellfoundation.org's website or the WPI website. And we talked about a lot of things. And so today what we wanted to do is just dig in a little deeper, answer some questions that you may have. And Annette and I are just going to have a conversation about maybe a little deeper dive into some of the slides and her experience with her daughter who has ME/CFS and has been ill for many, many years. So Annette, where would you like to go first?
So that we can give that background. Tell me a little bit about aerobic and anaerobic respiration and why that's so important in this illness.
And you have two predominant energy systems. And as a reminder, if one or both of them aren't working efficiently, there's a problem with producing energy. And so what we have found through our research with 2-day cardiopulmonary exercise testing is that long-term energy system does not work well. And so you have a backup emergency energy system, your anaerobic system, and it does seem to be working, but it causes lactic acid. It may also be impaired. So you may have two energy systems that don't work. We really know that the aerobic system isn't working. And so your only alternative, if that system is sick, is to rely on that inefficient system that only gives you 2 energy units per glucose molecule instead of what you should be getting, which is 36.
And one of the things that we've been concerned about is how to get that information to a physician that we're seeing, because most doctors, when you go in and you're a brand new patient, unfortunately, their idea of the illness is that it is some kind of an abnormal fatigue that can be repaired through exercise. And so they're giving patients the just exercise and you'll feel better, which is understandable in other diseases where that in fact does support the immune system and helps the patient feel better. But you can tell us a little bit more about why that is not the best prescription.
You know, we are so concerned. I want to be really clear about the use of graded exercise therapy. It is what is being recommended, and it is what is doing the most harm, I think, to our patients. The automatic response of anybody who's chronically ill is to try to exercise. And with ME/CFS, it doesn't work. It's like poison. Our mantra is do no harm. And so if you do something and it flares up your symptoms, it's the wrong thing to do. In fact, we're so concerned about people using graded exercise therapy with an energy system that doesn't work that we've written a letter of opposition on the harms to caution doctors, because we have had so many patients tell us, I went to my doctor and they said, you just need to walk, you just need to exercise and you'll be fine. And so in response to this, we wrote a letter that you can take to your healthcare provider. It's on our website about why you don't want to do this. because it does cause harm. And all of the research groups, many of them now are adopting exercise as a stressor to elicit symptoms to study the illness and to study post-exertional malaise. This doesn't mean this is what you want to be doing to improve. In fact, what will happen is patients that engage in exercise aerobically actually get worse. And that's the last thing you want to do. You want to preserve your function and improve your ability to do more. And that's why energy conservation and energy management is the starting place. And eventually, then we can hope to look at reversing deconditioning or stopping that downward slide.
Out ourselves, our patients figure out for themselves what their envelope is, what is their basic starting point, and then how do they check themselves? Is there some way they can check themselves to know that they need to stop, that they are at that envelope?
Well, the way to do it, if you're physically able, is we do a 2-day cardiopulmonary exercise test. And the reason that we recommend that is that it gives us heart rate at anaerobic threshold. It actually measures objectively your total oxygen consumption, and that puts you in a functional impairment category. So when we look at the results of a cardiopulmonary exercise test, we can tell a patient that they are moderately or severely functionally impaired, and then what heart rate at their threshold is so that they can pace activities at or under that heart rate. More importantly, we bring people back a second day so that we can take a look at any differences between day 1 and day 2. And our research and Dr. Keller's research has showed that between day 1 and day 2, there is a 50% drop in workload at the anaerobic threshold, which means patients are completely different in their ability to sustain energy by 50% or more, and that's the average on day 2. And so you can imagine that heart rate might look different. So if you're trying to pace at a heart rate on day 1 on a good day, but you're living your life in post-exertional malaise on a bad day and sustaining that, there's this gap. So you may not realize that you're constantly overdoing and causing PEM because you're pacing at the wrong heart rate. And it's always lower than patients think it is. So that's an additional issue.
I really think that is so informative, because you can understand how somebody who, especially someone that's been ill for a long time, and they now have rested, they get to a certain point and they feel like, okay, now I've got to make up for the 4, 5, 6, 7 days that I didn't get anything done. And I'm going to go ahead and do all of those things while I'm feeling good, not realizing that what they're going to do is now they're going to crash again for another 2 weeks. And I can remember when my daughter was younger, the doctor basically saying, look, your daughter right now, her energy looks like this. Her health looks like that. He said, I want you to get like this. I wonder if you can see my hand, but I want you to get just as smooth as you can so that you don't have the hills and the valleys. That was the way that he described it. And I can tell you that when she was bedridden, we had no idea what it meant to start an exercise program until you came along and were able to give us the real detailed information. And I was wondering if you could tell those people who are bedridden what their expectations really ought to be. It's not that you should be ready when you feel better to get up and vacuum the living room or do your dishes or maybe even take a shower, but we're really talking much, much smaller increments. And I didn't realize that until you came along. So if you might want to share a little of that information, if you would.
Well, and that again is why energy conservation is so important, to save what energy you can, be more efficient in doing your daily tasks so that you can do more without post-exertional malaise. And that's baby steps. And so any type of an exercise or an activity program doesn't mean going back to the activities you used to do. It means really changing those activities. So instead of going out and walking, we're talking about maybe strengthening your hands and core, and just very, very one to two repetitions. And any patients that I've worked with, they don't really think of it as exercise because it is completely reconceptualizing just range of motion and using muscles that haven't been used in a long, long time. You know, it's a very slow, gradual process. You're on mute, I think, Annette. There we go.
I know I didn't realize when you were talking about range of motion exercises, but that was really where we started making progress, was when that was the only exercise that was going on. And then gradually lifting the legs and gradually lifting the arms and the neck and so forth, to get to the point where you can manage to sit up for so many minutes a day and then swinging your legs over. So I think doctors would probably be just astounded when we talk about that. That's where a lot of these patients are starting.
Well, it's astonishing because our severely ill patients, and that's 25%. And anybody, by the way, that's in a PEM crash, they're severe, they're in bed. And so I think most patients, if they're mild to moderate, they think, well, that doesn't apply to me. I don't need to hold back like that. And yet when they overdo, most patients have this roller coaster push crash mentality that they get a little bit of energy, go absolutely crazy, right? Riding that roller coaster, but they always crash and burn. And so really the slow and steady approach is the right approach. And it's very small increments and very, very careful planning. I think one thing that patients are always surprised about is I always recommend starting exercise with breathing. Diaphragmatic breathing, just to make sure that oxygen is getting to the tissues. Most patients are hunched over. They breathe very shallowly. They have a lot of shortness of breath. And so the respiratory muscles are the most aerobic muscles in the body. And so you can imagine if that system doesn't work, just breathing all day long is exhausting, because even the oxygen cost of breathing might be too much for some patients and is causing them to dip over into that emergency system. I mean, that's just mind-blowing. It's crazy. So
now, I'm sorry.
Yeah.
I was just going to ask you, have you seen patients like that who benefit from the oxygen concentrators, that are those people who are so ill that, you know, they're using their energy in breathing?
I've got a big reverb going. I don't know if you are hearing it on your end. Oxygen concentrators, you know, I can't prescribe that kind of thing. We do have worked with physicians that do use them, and some patients find them beneficial. Some patients say that supplemental oxygen is beneficial. Certainly anything that you can do naturally yourself, which doesn't require the addition of anything. Everybody can breathe. And I can recommend diaphragmatic breathing, breathing deep into your belly. Put a Kleenex box on your stomach and see if you can get that Kleenex box to move. Don't do it for 20 minutes. Start with 1 or 2 breaths, 3 seconds in, 3 seconds out. And that's a great starting place.
So I noticed that we have a question down below, and you and I have talked about this before. They want to know if there are other places that they can go to get the evaluation if they can't get to you. And if you could tell us a little bit about some of the pros and cons of that, that'd be very helpful.
There aren't too many places in the United States that offer 2-day CPET that are familiar with ME/CFS. And so you want a facility that is familiar with the disease, because you may have the test done and it might not be interpreted properly. And so one of the major problems that we have experienced is patients go to other facilities and say, have it done by a cardiologist. Well, that's fantastic if you're looking to see if you have a heart problem. We find that it's often used against them for disability because they don't look at or understand the nature of the cardiopulmonary exercise test. And they'll say that if they don't have a heart problem, a serious arrhythmia, that they're just fine and not disabled. And then that goes into their medical record, and it's very difficult to rebut. Patient sends us the results, and the results say they're severely functionally impaired based on their oxygen consumption at peak or at their anaerobic threshold. So there's that problem, and the problem of interpretation. There's also the problem of technically doing the test correctly. And we've written a whole methodology paper thinking, oh, we'll get a methodology paper out and anybody will be able to do it. And that was our goal. But we found that most labs don't do quality control testing or biological validation. And what that means, especially if you're looking for a disability evaluation, is the equipment isn't working and they don't know that it's not working. And our analyzers that measure oxygen consumptions tend to drift high, which is not what you want for a disability evaluation. You want an accurate measurement. So we would recommend that you go to a facility for testing with somebody familiar with ME/CFS and make sure that you're asking if they do biological validation so that you know that the equipment is working properly.
Take information of their doctors at the various places in order to try to educate them. Would your paper that you've written describe it enough in detail that somebody should be able to run that test? I mean, I know your other problem is that it may not be accurate because they don't check their machinery. But there seems like to me that there would be some places that would take it very seriously and would be able to, do that 2-day testing, even if they didn't know how to interpret it, they would at least have the raw numbers. So, have you come across that at all?
Unfortunately, we haven't. We have had a lot of facilities and a lot of patients try to do this at exercise science labs, at hospitals, at doctors' offices, and we just rarely have found them to be successful with it. Not due to lack of effort, but.
So, I'm sorry, I was on that whole time. I hope that didn't interfere with the sound.
No, you're
I was looking, I was looking at a couple of places and really hopeful. So, is there any way that you can recommend that patients themselves can self-monitor to at least get an idea of, so in other words, their heart rate? What do you recommend? Do they wear some kind of a wearable? Do they just take their pulse? What's the best way for them to do this?
So this is a great question, and it's very complex because, as I mentioned in the other webinar, we have a couple of issues. We have a heart rate response that is not normal, meaning that the heart rate is not increasing normally. So using an age-predicted formula is problematic. And then we have the 2-day CPAP problem, which means that in PEM, you're a different person. So you really have to be cognizant. That said, we always recommend you err on the side of caution. And so take your resting heart rate for a week to get a good baseline average. And one thing that you can do is chart your resting heart rate. And if it's 10 beats higher or 10 beats lower, there's a problem. The other issue with heart rate monitoring is orthostatic intolerance. And so that means the upright posture causes problems. So if you are upright and your heart rate jumps up 20 or 30 beats when you stand or when you're sitting up for an extended period of time, that's a problem because that doesn't mean you're in anaerobic metabolism necessarily. It may just be a consequence of being upright. So now you have static, right? You have noise that makes the heart rate monitoring process a little more difficult. So you pair that with the not knowing, right? If you don't have any objective evidence to show where that heart rate should be, the conservative estimate, and we've looked at a couple data sets and we need to explore a little bit more. Now, granted, we're not including bedridden patients in this because we can't test them. So keep that in mind. But a safe place to start would probably be 15 to 20 beats above the resting heart rate. And that doesn't give a very large window. That's a pretty small window for monitoring combining that with making sure you don't have symptoms. So making sure you're not going over that heart rate for more than 30 seconds to a minute, and then also making sure that it's not causing you any symptoms of post-exertional malaise.
Well, it certainly sounds complicated, but it's absolutely critical. And your tips that you're helping everyone with, and especially that slide that talked about all of the ways that you can meet your needs. I think sometimes just checking to see how you're feeling during exertion of any kind is just one of quite a few of your tips that you had for checking out, really for staying well or for feeling better. And you mentioned that in one of your slides, for instance, getting a little sunshine in the morning and that it helps you sleep. You mentioned an emotional, checking yourself out, your emotions, and providing some beauty and some calm and peaceful activities, whether that's reading, favorite poetry or watching something, and avoiding a lot of the extra stress. And right now, in our world, especially, you turn on every TV and there's news everywhere and there's something bad happening everywhere. And so we probably could do a big favor for those that we take care of by helping them have a more peaceful environment, providing them with the kinds of things that are comforting. And we did get, thank you very much, we did get some feedback from one gal, and I don't have her name in front of me, I'm sorry to give her credit for this, but she said one of the ways that she does it is she adopted a couple of cats, and cats love to lie around, and so she cuddles with those cats who don't want to be bothered, and it reminds her to take the time to rest. It's a very calming activity, and she said that's really helped her feel needed as well and important. So I was just wondering if you wanted to pop up that slide again, or if you wanted to, if there were some other things just to remind us of some of the things that we can do to help our loved ones feel more comfortable.
Sure. Yeah, you'll have to change the view so I can advance the slide set. But absolutely. If you can add uplifting things into your life, I wanted to mention also that, bear with me here as we run through it. Whoop, too far. Oh, this is the roller coaster and the activity avoidance. It's also really helpful to identify what your activity coping style is. We didn't get to this because we were in a bit of a time crunch last time, but there are two distinct coping styles in the illness. And the idea here would be not to be on the extreme end of either of them, but to get off the roller coaster, to have that consistent energy, but also to be able to safely get off the couch. I went a little bit too, here we go. Starting and ending each day well. And the importance of adding things that give you joy, that are uplifting in your life are so helpful. But remember that you don't want to overdo those. Even positive stress is a stress that can cause PIM. And so start in very small increments. But today was the first day in a week that we've had good air quality, and I could not wait to get outside. I was so excited this morning that I could just take my coffee and go sit outside and start the day outdoors in the clean air, in the sunshine. Had my big glass of water, got hydrated. Maybe we could talk about hydration and the importance of hydration for a minute, because dehydration is the #1 cause of fatigue for athletes and for everyone. And just by hydrating, now that on top of that in ME/CFS, there's all of the orthostatic issues. So hydration and oral rehydration becomes even more important. But just starting your day with 8 to 16 ounces of water. If you want to start it with oral rehydration, that's great too. But just being mindful that dehydration, a simple thing, a little fluid loading, a little fluid and salt loading can really give you a boost in a very positive way. And none of these things cost. They're all free. They're all things that you can do at home. You don't have to go anywhere. And they're joyful. They're fun things.
that it's important to add some kind of a hydration salt to their water a couple times a day. And you had recommended a product. Maybe you could talk about that just a little bit.
Yeah, I think I recommended it. The product that we provide to our patients after testing is called Normal Light, and you can use it. And I think Dr. Meadows, who did a presentation on oral rehydration, you just want to make sure that it has everything you need in it. I believe the other one that he mentioned was Janus Brothers, and I think I have it right here. Let me pull it down for you. We don't sell products. We're not endorsing products, but just, you know, I think the World Health Organization uses this one, and it's Normal Light. So this one's plain. They come in flavors, but it doesn't have preservatives. It does have dextrose, though. So it gives you sodium citrate, chloride, potassium chloride, citric acid, and dextrose. So what you want is to make sure that you're not over drinking without electrolytes, and not adding a ton of extra sugar. So, you know, conventional sports drinks have so much sugar that you have to be careful with those.
We have a question down below as well. We are being asked, does sluggish fatty liver cause chronic fatigue or fibromyalgia and low energy levels?
Well, I'm not a physician and I don't diagnose. I'm not sure that any studies have been done on fatty liver that I'm aware of, and as a cause of ME/CFS, although I'm sure that any chronic illness can trigger you know, more fatigue. And so using energy management principles, making sure you're not flaring up your symptoms is really important.
Understands ME/CFS or fibromyalgia so that they're getting the appropriate treatment?
That is a great question. I, at this point, would encourage you to find a physical therapist that is open and willing to work with you, that isn't espousing no pain, no gain, and push as hard as you can. And the first thing most physical therapists want to do is put you on the bike, because that's what they do with everybody else. Bike or treadmill, 10 minutes, give you a good warm up. Well, if you do that in this illness, you're done. You won't be going back to see them because your symptoms will be flared up. If it's one of our patients, we recommend that they take their cardiopulmonary exercise test results to them. They can also take a course. So if you find one that's willing to work with you, say, hey, Workwell has a course on MedBridge that you can take to learn how to manage this condition. We also have resources that you can point them to on our website. If they're not willing to do that, we have short videos. Say, hey, you need to understand post-exertional malaise, and then I have to do really short intervals, followed by rest. Wear a heart rate monitor during the session, because that heart rate going up 30 beats when you stand up should be an eye-opener to your physical therapist. If you have your heart rate at threshold, you can use that. If you don't, you can say, hey, if it goes over 20 beats, you are doing something to me that is not right. And then they can watch that heart rate during your session. The other thing you have to do is monitor how you feel the next day. Your therapist only sees you in your physical therapy session. And if you don't tell them that they made you worse, they can't adjust. So that's what I recommend right now. Our hope is that in the future we can train physical therapists. We'd love to develop a virtual clinic to provide rehab services virtually. We're not quite there yet, but that's a direction that we're heading in.
So you mentioned to me that can you tell us a little bit more about what you're planning in terms of rehabilitation? And
well, our goal is, yes, to develop educational materials. And so, you know, we're doing that. I think the first fire we want to put out is that graded exercise therapy is not the way to go. And so you can download that letter and take that to your physical therapist or your physician. If they are encouraging you to do aerobic exercise, say, no, Workwell Foundation, who has done all this research, says that this is not the way to go. That's number one. What we're trying to do is we developed Todd Davenport, Mark Van Ness. Dr. Davenport is a professor. Both of them are professors at the University of the Pacific. Todd is in the physical therapy department. They have put together continuing education that PTs can take. So they can actually get credit, continuing education credit, and learn how to work with ME/CFS. So our goal was to provide that and as a framework, and then get physical therapists and occupational therapists and nurses that are interested in that program to take the course and then reach out to us if they're interested in working with patients. And so that's our first step. Is we just rolled that out in the last year. We're having physical therapists that are taking the course. They're getting educated about the illness. And then our next step would be to work with and find a group of physical and occupational therapists that want to work with ME/CFS patients and could do so remotely and virtually. And so we are in the process of training a group of professionals to be able to see patients in a virtual setting. So that's our next step.
And the fact that it's virtual, it's amazing that there are some silver linings to this whole COVID experience. And part of that silver lining that I've seen is that we're relying more and more on virtual lessons and virtual communication, and probably getting a lot further in the disease like this, where you're isolated, where people can understand, oh, well, you can't get to the doctor's office. Now my other patients can't come either. I understand that. So it's been, while it's been difficult to adjust to a lot of the changes for people with ME/CFS who have been in this situation for years at a time, it's not anything new. And if anything, they're getting better service now than they had before, when people were when everyone was just able to go as they pleased. So I'm looking for those silver linings every once in a while, finding them. Let's see. What do we have? Oh, somebody wants, let's see, someone wants to know, would that heart rate have changed over the years? So with the illness, do you see changes either progressively worse or improving, and or with age and maturation? Do you see?
So yeah, really good question. And we've seen both. We've seen both patients improve their heart rate at their anaerobic threshold through a good self-management program. And that's really exciting. So we actually have a case study of a patient that had a cardiopulmonary exercise test, started listening, wearing her heart rate monitor religiously, staying under her heart rate at threshold, able to do more, then gradually added some very low-level body weight, range of motion type exercises, and tested again a year later and was able to improve her heart rate at her anaerobic threshold by 30 beats. I mean, that's insane. And her cardiopulmonary profile changed too. Her heart rate responses went up, her blood pressure responses went up. And so that's why when I say, don't cause an inflammatory response, every time you're in PIM, you're making yourself sicker. And just by not doing that, she showed improvement. Other patients that I have seen over the years improve are patients on different therapies. So some patients on antivirals, on immunomodulators, whatever, you're working with your physician and you're finding a treatment that helps you feel better, that heart rate at threshold likely is improving. And that's exciting. So you have to kind of combine without testing again, what you can do is you can do a little trial. You can bump your heart rate at your threshold up 5 beats and see how you feel. But you always have to take into consideration What are your other symptoms? What other stresses are involved? And then if you can tolerate that, I mean, that is the goal, is to bump that heart rate at threshold a little bit higher and a little bit higher so that that window opens up and you can begin to do more.
One of the things that a lot of families have is difficulty communicating to a partner or to a caregiver about their abilities and their level of illness. Do you have some kind of a chart or something that a person could use to describe that allows them and helps them describe where they're at in any particular day? Because it seems like to me that it's really a task to try to describe the symptoms. But if you've got them already written out on a paper, and then you can maybe X, next to a symptom, or I'm at a 1 and not a 10. We use that a lot in my family. Andrea will say my daughter will say I'm at a 4 or I'm at a 6. And then everybody has a similar understanding. Oh, okay, we know now what to expect. Do you have something like that?
So this is why I love the cardiopulmonary exercise test, is that it provides that objective answer. And when I meet with patients to go over their results, I can tell them, you're severely impaired. So of course you can't take a shower without being in anaerobic metabolism and having symptoms. That oxygen cost for that activity is more than you have available. And that puts it in very objective, black and white, identifiable. It's identifiable. And you can put a heart rate monitor on, set that heart rate monitor, and set it to alarm. So when that alarm goes off, beep, 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 the family member knows you're in your emergency energy system. And it's powerful for physicians. It's powerful for patients. And I think it's powerful for family members that don't believe you. Or even our patients, they don't believe themselves. They're like, you really found something? You mean it's not in my head? And I'm always surprised that our patients are disbelieving themselves because they've been so disbelieved by their family members. And then to add to that, that's why we're continuing to do the research on post-exertional malaise. And if you want to go to that slide, I'm having patients begin to characterize their symptoms and where they are in terms of immediate, short-term, and long-term post-exertional malaise. And it's so helpful because if you say you're in long-term PEM, that means you're in a flare-up. That means you're having immune symptoms. And so I'm hoping that we can begin to educate healthcare providers so that you can go in and say, hey, I'm in long-term PEM, which means it's involving my immune system in a sustained immune response. I'm really sick. You can hand them our PEM time course, which is a 1-page handout, or we can make available our figure that spells out, here are the symptoms in these categories. Now you want to avoid them, but you can't always avoid the immediate. And so most patients are living in short-term and long-term PEM. Our severe patients are in long-term PEM, and that's where their life is. They're not getting out of that because of that chronic inflammation, that sustained immune response. But if we can get patients to start talking in these terms to their healthcare providers, if we can educate healthcare providers about immediate short-term and long-term consequences of PEM and the systems they involve. So remember, the short-term PEM, that's starting to involve the brain. That's starting to involve the autonomic nervous system, which means you're more susceptible to dysautonomia. When you stand up, you're going to be flat for a while if you've overdone, if you spent too much time in that emergency energy system. Your doctor should be able to see, oh, now they're flat. Well, why are you flat? Because you've spent too much time there, but they may want to target a treatment toward that. And I know that research has been done using an exercise challenge to look at orthostatic intolerance, and that an exercise challenge creates orthostatic intolerance. How interesting is that? So if we can begin to get patients talking to their loved ones saying, I've got some long-term PIM going on. I'm in an immune response. I'm not going to get out of that. Or when the heart rate monitor goes off, hey, that heart rate monitor is going off. That means inflammation, 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 right? You need to stop so that you don't progress those symptoms and so that you can get out of them. And if you're really functionally impaired, which our patients are really, really functionally impaired, you're not going to be able to stay in immediate. You can identify the immediate, but the goal would be to stay out of long-term PEM and stay within that immediate to short-term response so that you're not in bed for a week at a time or months at a time because you got a little bit of energy and then you went crazy on the roller coaster and now you're in bed.
Of the restorative, very, very low level exercises. And that made me think that maybe that's another sheet that you might produce that says, this is what we mean when we're talking about rehabilitating the most severe. Some of those simple little ankle twirls and, those kinds of things that they just don't have access to.
Right. And that's exactly the direction we're heading. We wanted to set the framework, and COVID and the California fires have slowed down our timeline of progression here. But our goal was to just talk about 2-day CPET. And so we've done a webinar on that to talk about graded exercise and create some videos on what's the problem there? Why don't you want to do that? So we have several videos and webinars on graded exercise therapy, post-exertional malaise, the 2-day CPET and some of our research and what does that mean. And now we've hit energy management, which was the next in the progression. And all of those things, you have to have that foundation of understanding before you think about moving into exercise. And so I think our next webinar that we're hoping to do will be on heart rate monitoring, because tying the heart rate monitoring into the symptoms in PEM is the next step. And then after that, before we ever get to, everybody wants to start with exercise, and that's the last thing we should be starting with. You've got to get a handle on the pacing self-management, reducing your symptoms, identifying PEM. And this is a lifestyle change. It takes practice. It sounds simple. Even the heart rate monitoring, it takes a long time to figure that out. And then to learn to perceive it. When are you over? So you don't need that heart rate monitor. You can learn when you're over your threshold and how you feel before you get there. So that's the next webinar. And then after that, then we'll begin to address exercise and what that looks like and how that can be restorative rather than harmful.
Now, do you recommend the chest heart rate monitor over the wrist monitor? And where would somebody be able to purchase one of those?
Absolutely do. So the chest strap, the reason for that, it's uncomfortable, and I understand that. It's also accurate. When people have poor perfusion and they're not exercising, so poor blood flow, if you have poor blood flow, you need a chest strap to identify that. And even the chest straps are designed to be used for people that are exercising, so they get good contact. So you need to wet the contacts or get electrode gel on the contacts, even with the chest strap. All of the wearable devices, for as much progress as we've made, can be up to 30 beats off because they just don't get the signal. And this is for a healthy person. So if you've got reduced blood flow to your extremities because of orthostatic intolerance, because of a reduced heart rate response, you're not going to get blood flow to your wrist or your finger. And so most patients don't have a window of 30 beats, much less if the air is 30 beats off. We recommend a Polar heart rate monitor, but you can use any heart rate monitor with the chest strap. Polar is just sort of the industry leader that all the athletes use. But there's a bunch of them out there. Get the cheapest one you can find that will alarm, either vibrate or alert you that you're over your threshold. That's what's important. And you don't have to wear it all the time, just until you get a handle on what it feels like to be over that threshold and what is causing your symptoms. So that's a whole separate area, but that's the nutshell version.
all of your advice and all of your knowledge. And thank you also for putting this up where we can go back and take a look at it again, and for all of your information. So that's at the Workwell Foundation info ad. Is that correct? Workwellfoundation.org.
Workwellfoundation.org is our website.
Right. And then we are going to begin adding the information as well at wpinstitute.org. And then you can go to YouTube to find some of these presentations. And they're excellent. They're very, very helpful for anyone who also wants to share that with a family member. I always find it's a good idea to have someone that you're close to that understands this illness and is willing to learn with you and willing to take a look at these things. They go with you to your appointments or whatever. So a caregiver, a best friend, a family member, somebody, but it's very, very helpful. And I just, again, I want to thank everyone that came today, and thank you for your questions. And we do hope that these are...
I have one more resource to mention, if I may, and that is if you're looking for a self-management program, Dr. Eleanor Stein up in Canada, she's an MD, and she has developed a Pathways to Improvement program, and it is a group online self-management program designed for ME/CFS, fibromyalgia patients, and environmental sensitivities. So I highly recommend Dr. Stein's program. She does not promote graded exercise therapy. She does not promote cognitive behavioral therapy. Even though she's a psychiatrist, her modules are on helping you sleep better, learning more about your energy and activity. And so if you're interested in that, I would go to her website and check that out. It's a great resource. It's EleanorSteinMD.ca.
today, and thank you all of you viewers, and we look forward to the next webinar. Take care.
Okay, thanks everyone for your time.